Type 2 diabetes is a very complex disease, so we do have the hyperglycemia, but in parallel we also have hyperinsulinemia. So in the past we only had the chance to treat hyperglycemia with maybe 2 agents that were sulfonylureas and metformin, and then we had to add basal insulin, for example. But basal insulin, of course, only adds to the amount of already circulating insulin. And with that hyperinsulinemia, we get more insulin resistance. We also have a gain in body weight. We do have, of course, a control of glucose levels, but at the same time, we do have the risk of hypoglycemia. When we now add novel agents that help us to become more insulin sensitive, to have the insulin work better, to suppress the gluconeogenesis, all of that are beneficial effects. And when we then think of the GLP-1 receptor agonists, they have a pleiotropic mechanism of action. So here we do see that insulin action at the muscle tissue is improved. We do see that also they have other effects such as the suppression of glucagon secretion. They also help us to have earlier satiety feelings so that people do not eat so much. And they do have a mechanism that works also on the brain that also drives the satiety effects from that side.
Type 2 diabetes is a progressive disease. So even though we have like oral medications and GLP-1 receptor agonists, eventually some patients will need insulin for the glucose control. In the old days, before we have GLP-1 receptor agonists as injectable therapy, or now we have also orals, we have to move patients to insulin treatment if they cannot be managed properly with oral agents. Since the introduction of GLP-1 receptor agonists, now the guidelines recommend if your patient needs injectables, you can start from GLP-1 receptor agonist, which was supported by the clinical studies that, as compared with like basal insulin or other insulin treatment with GLP-1 receptor agonists were associated with less weight gain or even weight loss, less hypos, probably better glycemic control. So now for those need insulin treatment, should we give them insulin alone or combined with GLP-1 receptor agonists? So that's the purpose of the current study, and also this has been demonstrated by this once daily fixed ratio combination between liraglutide and then insulin degludec and other combinations. Dual trials, it's clearly demonstrated when you combine insulin with GLP-1 receptor agonists as compared with insulin treatment alone, you do have less hypos, less weight gain or even weight loss, and probably better glycemic control.
So what we can say that both products that are in that combination therapy have been vastly tested in phase 3 clinical trials. So we have the Onwards trial program that investigated the once-weekly insulin formulation, and we have the Sustain trial program that investigated the once-weekly GLP-1 receptor agonist therapy. And both trial programs showed good efficacy in terms of glycemic control. We also had specifically of interest for that type of insulin where you might be afraid of injecting instead of 10 units a day, 70 units a week, where you might be afraid to cause hypoglycemia because of that high concentration of insulin that you immediately inject. But also there we've seen a very satisfactory safety profile. So we did not observe increased rates of hypoglycemia. And now that we can combine those two drugs into one medication, we can start slow and titrate slowly, especially in those who are insulin naive at the beginning, because then if you have like a slow titration over time, people will tolerate the medication easier, especially when we think of the side effects of the GLP-1 receptor agonist. So people will have less nausea, less vomiting, less diarrhea if we have a slow up titration.
The requirements for drug approval by regulating agencies will have a fixed ratio combination. You really need to demonstrate that it's superior or than the single components. So in the case of IcoSema, you have to demonstrate IcoSema is superior. Its insulin components is icodec or semaglutide. So this is the purpose of the combined trial. So we have a combined one, which was carried out in based on insulin treated type 2 diabetes participants and randomized them to either IcoSema treatment or icodec treatment, and then combine two in population that experienced GLP-1 receptor agonist. For those that cannot properly controlled by GLP-1 receptor agonists, they were randomized to IcoSema and then semaglutide. There's also the third trial, Combine 3, which really try to explore the clinical utility of IcoSema. So that in that trial, IcoSema was compared with basal-bolus insulin treatment. Now there's a still Combine 4 trial is ongoing, which is carried out in oral agent-treated type 2 patients. That's still ongoing. So far, Combine 1, 2, 3 trial has completed. In the Combine 1 trial, in that trial, we have 3 hypotheses. We hypothesize with IcoSema treatment compared with icodec, will have better glucose control, less hypos, and less weight gain. And then actually the data that we got from the clinical studies demonstrate this. Because as compared with icodec treatment, we have an additional 0.66% reduction of HbA1c, which is superior from a statistical analysis. Also, there's a difference in terms of body weight of 3.7 kilos between the two groups in favor of IcoSema treatment. In terms of hypoglycemic, as compared with the icodec treatment, IcoSema treatment was associated with more than 72% reduction of clinical relevant hypoglycemic or severe hypoglycemic. So that study demonstrates as compared with insulin treatment alone, which is also a weekly insulin preparation, this fixed ratio combination between icodec and the semaglutide was superior in glucose control, body weight control, and also has less hypos. For in the Combine 2 trials, it's a combination between IcoSema with semaglutide. This is superiority design. This IcoSema has a superior glycemic control, and the data also support that. In terms of body weight changes, there's a slightly higher body weight reduction in the semaglutide group. This is purely due to the high amount of semaglutide usage. It's 1 milligrams. Then the semaglutide components in the IcoSema formula.
Combine 3 looked into maybe the most challenging population of people requiring basal and bolus insulin therapy. And that were people who were already on basal-bolus therapy, who were then either switched to once weekly basal insulin or IcoSema in that comparison. And of course, if you can imagine people who then had not only the insulin component, but also the GLP-1 receptor agonist on board, that can help us to obtain good glycemic control without increasing the risk of hypoglycemia. Specifically in the study, the goal of non-inferiority was achieved. So we had non-inferiority in regards of glycemic control. And so that's also very reassuring that we can achieve good control without gaining weight. And also importantly, we had lower rates of hypoglycemia, and they were also significantly different between the two groups.
Now we have a lot of innovative therapies for like diabetes, obesity, and other health conditions. How to bring this to the clinical practice as quick as possible. This is unmet needs. In the old days, many drugs, when they were developed outside China, China are far lag behind in terms of running clinical studies to demonstrate efficacy and safety of these innovative medications. But now with this MRCT design, China have a chance to participate in global trials from very start of the clinical development, like from phase 1 to phase 3. These allow those medications which are badly needed in the clinical practice to be able to prove almost at the same time across different countries or regions. So this way we can bring the innovative medications to all people around the world at the same time. So I think in the future, many Chinese companies developed drugs also can be tested in the same way, and then people outside China may be able to benefit from the innovative drug development.
So as I said, we already seen the larger acceptance of once weekly drugs. And now that we have a combination drug that only needs to be injected once a week, that means that you have only one injection rather than 2 injections per week. And also that will be positive in terms of acceptance by the people with diabetes. If you think of like our busy and hectic lives that everyone has, if you have to think of one hurdle less for you, that's a big achievement. And also when we think of combining that maybe even with more enhanced titration tools where they help us to adjust the therapies when needed, maybe combine it also with continuous glucose monitors when we can see more in-depth profiles where we can even more adjust, or when we can suggest to add more exercise or look better into the food behavior. So I think all of that will be relevant effects in the future.
I think this weekly fixed ratio combination between the weekly insulin and semaglutide will have a lot of clinical applications. For example, currently we treat patients that need insulin with either insulin alone or in combination with daily injectable GLP-1s. But in the future, we can move them to weekly GLP-1 and then insulin formulas. This will reduce the injection burden, and also can improve the quality of life, improve the adherence to the treatment, especially with the components from GLP-1s that also have other benefits, such as blood pressure lowering, improvement in lipid profile, and also other benefit that has been demonstrated from these outcome studies.